I'm delighted to introduce two of our bright AIMI Summer Program graduates, Taylor Tam and Nidhi. Taylor is a rising freshman at Stanford and will be studying computer science on the AI track. Congrats. She's interested in application of AI ML to the medical field, particularly in diagnostic and imaging. Nidhi is a rising senior from Limbrook High School. Nidhi is very passionate about AI for social good. She has so many contributions and research using AI for stem cell differentiation, doing a lot of mentorship and exploring AI for education and journalism. Taylor and Nidhi, we're excited to have you. Please take it away.
Thanks, Ala. As Ala said, I'm Taylor. I'm an incoming freshman at Stanford, and I'm studying computer science. I'm really interested in the intersection between AI, ML, and health. I've been working on several projects in the area involving computer vision, and I participated in AIMI's first summer research internship. And I'm really excited to learn more from Dr. Mega today.
Hi, my name is Nidhi Parthasarathi. I am a high schooler from Limbrook High School in San Jose, California, as Salah said. I'm really interested in the intersection between AI and health, and I've been working on several projects in this space. I also had the opportunity to research more into this area through Stanford AIMI's first year-long internship in my sophomore year. And today I'm really excited to learn more about new technologies, including AI in medicine, from Dr. Mega.
Cool. So Dr. Mega, MD, and PH, is a leader at the intersection of technology, life science, and healthcare. She co-founded Alphabet's Verily and holds positions on the boards of Boston Scientific and the Danaher Corporation, as well as advisory roles with Research America, and the Duke Margolis Center for Health Policy. Dr. Mega's research has helped advance understanding in cardiovascular health, particularly in pharmacogenics. And now I'll hand it off to Dr. Mega. Thank you.
Thank you. It is wonderful to be here with you all. I want to make sure I'm now sharing my screen so you guys can give me a thumbs up if you can see the slides. We good? All right. As I mentioned, it is such an honor to be here with you all. I am a huge fan of the AIMI program and everything that is taken on, and particularly one of my favorite parts is what a vibrant community, as Joanna said, that's been created. And that includes people from all different backgrounds. So this is one of my favorite things I'm doing this summer, and just want to thank you all for inviting me. What I'm going to do is start with a little bit of a discussion around my own journey. And as I mentioned, we will have time for questions, so keep them coming and we're open to anything. So I was born in New York City. And I thought that I would probably live in New York City my whole life. But when we were I was about 8 years old, my parents moved to North Carolina because there were some really great opportunities there. And so I moved from a really big city to Eastern North Carolina. And while geographically they look quite similar on the map, it really was an entirely new environment that turned out to be really amazing. And some of my closest friends are still friends I made during that time. But the reason I bring that up is at a very young age, I realized that life is not just one linear path. You're constantly having changes. I'm sure many of you have had changes thus far in your life. Maybe you've moved from other countries, maybe you've had personal changes. But I think it's a really important lesson, because sometimes we think that it's just one step in front of the other. And sometimes when you get to a point in my career, it can look very linear, but trust me, there are many twists and turns. And I think that's what makes life so exciting. I then came out to California to go to Stanford for college. Had an absolutely wonderful time there. I had never been to California, so was certainly pleasantly surprised with many things, including the weather. I then moved to Boston into the Northeast to do medical training, and that included after college, if you want to be a doctor, you do medical school, and then typically you do residency and fellowship, and I'll talk more about that. So spent then many years in Boston on faculty at Harvard Medical School. But about 9 years ago, an opportunity came up to work with a tech company. We'll talk more about that. And that's what ultimately brought me back out to California. And I'm now very happily a part of the Stanford family. I get to see patients in the hospital through the cardiology division and also work with groups like AIMI. So again, this is a little bit about my own geographic journey. But in terms of finding the course in my journey to medicine, I always start with the idea of thinking about the problems that you're solving. And I know we have people on the line today. Some of you are really interested in the applications of new technologies in healthcare. We've already heard today people interested also in journalism, climate, potentially urban planning. There's so many big problems out there in the world to address. But I always want to encourage people to start with those. Start with the people that we're serving, and then we'll bring the tools. And that was very much ingrained in me when I went and trained in internal medicine and cardiology. I did my training at 2 hospitals. One's called Brigham and Women's Hospital. The other one is Mass General Hospital. And I included a picture of my co-fellows here. And you can see this is an old camera where they actually have a timestamp at the bottom on the bottom right. But here we were training, and we were part of the MGH program. We're standing with a picture of Paul Dudley White, who is really one of the fathers of cardiology. And through both my teachers and my co-fellows, I learned really what it means to care for people. So anytime we talk about the technologies today, it's rooted in trying to help people. And again, as I said, they can be in lots of fields. Health is just the one that I'm closest to. So as I mentioned, my motivation going into medicine was thinking about how do we care for people, but how do we bring amazing technologies? I mean, the advents in new life science techniques, AI, they've been expanding for years. And that to me was such a beautiful intersection. And I think finding joy at the intersection of different tools and patient populations has really been important. And it's manifest in 3 different ways. And we'll talk about these different parts of my journey, but also how they interrelate much more broadly. So my early work was in clinical trials. We'll talk about why clinical trials matter, why clinical evidence matters, and that's going to be true for a lot of different new technologies. I then got interested in genomics because if you're running studies, we should be extracting as much information as possible. I'll also talk about some of the highs and lows of early genomics research and applications, and some of them actually parallel this now world of data and AI, which I've gotten involved in this later part of my career. So we'll talk about them separately, but there's really a thread that goes back and forth. So let's start with clinical trials. I have a feeling that many people probably haven't thought that much about clinical trials or evidence generation, but anytime, and I realized this when I was at the bedside and taking care of patients, anytime we wanted to use a new medicine, or if we wanted to use a new device, let's say a new pacemaker, or a device that opens up the arteries in the heart, or even a new digital tool. You hear a lot about the hundreds of apps that are coming out every day to help people navigate their healthcare. Every time you have one of these new technologies, we want to make sure it's safe, efficacious, and that it actually works. And so the basic principles of clinical trials are first to start with, is something safe? And again, my early work was around medicines, and we wanted to make sure there weren't some really scary side effects. Now, again, with things that are lower risk, like some of the apps I mentioned, maybe the safety isn't as important, but we always have to think about safety. We have to think about efficacy. Is what we're working on going to actually help someone? We have to confirm the observations that we make, and then we need to follow up, especially as things change. Digital health tools, AI workflows, they change. So this is the basic pattern of clinical trials. And I just thought this was a great way to apply and study new medicines, to bring them, and medicines in their own way are biotech. It's a type of technology. And I joined a group called the TIMI Study Group, and they were affiliated with Harvard Medical School. And the group itself is organized to try to think about new therapies for patients with cardiovascular disease. And the studies also have an interesting feature. They tend to be quite international. So we were able to, and I personally was able to work with over 50 countries and over 5,000 different sites. And this list here is a list of the different study names. And I include them because it's just the way that we refer to different studies. Each of these studies typically had between 10 and 20,000 patients that we studied. The other thing that became important, and I share this just because it's part of my own journey, is I wanted to understand not only how to interpret the data at the end, but actually how to process all this clinical information that was coming in. And so I ended up also getting a master's in public health focused on epidemiology and biostatistics. And this was just when data science was starting. So data science as a concept would have been included in those kinds of those terms. But for me, it was really important to get my hands on the data. I didn't always do my programming. We worked with many people, but it was really important to understand first principles. So I was working with this group. And as an example, one of the studies I worked on looked at rivaroxaban, which is an anticoagulant, which is a blood thinner. And we showed that patients treated with this medicine who had heart disease did better. These are Kaplan-Meier curves, and you can see the event rates are lower. It's the darker gray line in patients who have this treatment. And so this medicine has gone on to be used in a number of different conditions. So this is an example of how you have clinical evidence that translates into clinical value because of the clinical trials. But it led to an observation. And personally, I thought, gosh, we're studying all of these people, and maybe you're working on data sets and you have maybe thousands of people in your data set, but there are unique features. People are different. And one of the tools that was coming out to understand personalized medicine were things like genomics and proteomics and metabolomics. And I ended up writing an editorial, and I picked the graphic on the right just to show you there's population health, and some of your observations that you're working on might be good for the entire population. But there might be things where it's really important to understand at a deeper level what's happening with individuals. And so that's what led to my second chapter, using new technologies. This time it was genomics. Now, what it struck is that we have to make sure that there's value in the same way that in the top left up here, that's the first stethoscope. People use stethoscopes because they add value. We use imaging. We now use digital tools, but we had to figure out the value. And interestingly, and we'll get to a parallel with AI in a minute, genetics and genomics studies had been around for a long time. Many of you, I'm sure, studied Gregor Mendel in 1865, understanding the early basics with peas. And I still remember my Mendelian genetics. But over time, there were advances. And by the time I was getting into the field of clinical trials, the human genome was being sequenced. And there was a lot of excitement because for the first time, we could understand at a much granular level what was going on. However, and again, this is where I talked about their ups and downs and trials and tribulations, and the world is not a linear line. There was a concept of genetic exceptionalism. And so we thought that the human genome had been mapped and everything was going to all fall into place. But, as you can see in this cartoon, this was a demonstration of what a bunch of genomes might look like if you don't put them in place. And then the top right shows a comprehensive review of some genetic association studies. And what that means is studies that look at certain genetics and they were associated with certain conditions. And as it turns out, despite hundreds of these associations, only six total replicated, which speaks to the fact that only 6 were real. And so we were excited about genetics, but we had to be cautious and we had to do a number of things. We had to think about advances, technical advances. There was the decrease in cost of high throughput genotyping and screening, so that made it easier to do the work. There was infrastructure. I'll talk about that in a minute. I'm sure a lot of you are working on technical infrastructure. There were new methods to understand the genetic architecture. We didn't really understand that. And then there were clinical advances going on, collaborations. I encourage all of you to collaborate. Science and certainly work in AI is a team sport. We had larger cohorts for evidence generation. We were able to start to replicate. And I said I'd go back to the concept of infrastructure. I ended up spending several years building out the infrastructure that we needed to do genomic research inside clinical trials. And I bring that up because I bet some of you are working on infrastructure and you kind of want to get to the results and you want to get to the endpoints, but sometimes it takes a little time to get the right data in place. And so I just want to, this is a note of encouragement to say that if you get the right infrastructure in place, you can start to look for findings. I won't go into a lot of detail here, but we ended up looking at a lot of genotypes in patients who we were studying. And it led to an early pharmacogenetic discovery that people with a particular genetic variant in chromosome P450, they had a different response to a medicine called clopidogrel, which is another blood thinner. And it was one of the most commonly used medicines. And we just didn't know that people were responding differently. But by using new technologies, we started to parse out. The top panel on the left is looking at pharmacokinetics. So that's how someone responds to the drug and how much drug is in their body. And you can see that there's different levels of drug based on your genetics. From pharmacodynamics, it's how your body actually responds to the drug, again, differing. And on the right, it shows two different curves. People who carried these genetic variants had higher event rates. So their event rates are higher than people who had non-carriers when treated with this medicine. So this was a way of building infrastructure, learning from the technology, and then applying it. And so that became really interesting to me. However, over time, what became true was that more pharmacogenetic associations were out there. And we even got to an era of genomic medicine. So it takes time to get to these real breakthroughs. And nowadays, we have treatments out there that are available for people who at some point thought they would never be able to alter their genome. And just a plug for Stanford, I heard that some of you are going to be there next year, in this upcoming year. There's amazing work being done to think about definitive and curative therapies. So a lot of work going on at the Stanford campus and certainly more broadly. But taking us back to the journey, and now we get into the final chapter. I was in Boston. I had told you that I love patient care. I was working on clinical trials to study evidence, embedding genomics. We had built out the infrastructure. But it became pretty clear, and this again is about 9 years ago, that the path to precision health, so precision medicine is what we refer to when we are precisely working with someone's medical history, so maybe like their genome. But people are starting, and I started to use this word precision health, which is when you start to look more broadly at inputs, things that come from in clinic, from at home or remotely. And if you look at the amount of data that's out there, and this is on the left-hand side of the slide, it was estimated that there was going to be a 1,600-fold increase in health data. And that's data, I'll tell you, it was very hard for us just to organize the genome data. We would carry around external hard drives. This was before cloud computing was as ubiquitous. And we spent a lot of time figuring out not how to compute, but where to compute. And that might come up in the question and answer session, but there's been a lot of evolution. And I think now we're in a period of time where we can use these technologies more seamlessly. But I got a call from the IT division of the medical school saying, you're taking up way too much space and you're costing way too much money. And this was all on-prem. And I thought, gosh, okay, well, I'll talk to someone in IT. And they said, we are IT. So I realized I was going to need to be on this journey along with the IT colleagues to figure out how to actually deal with all of this information. And I ended up talking with a number of tech companies to try to see what was out there and what kind of platforms would be able to scale. And it was through those conversations that I actually ended up joining Google and joining X, which was a branch of Google. And at the time, it seemed a little bit odd to be, the far right panel is representing healthcare and life science, but we had people working on autonomous vehicles, on ways of new access and energy. But while these disciplines seem different, and at the beginning of the talk, I really talked about finding problems that you want to solve. What was interesting is the problems were different on the surface, but much of the infrastructure. So if you think about autonomous vehicles that have to take into account maps that are broadly around them, they have to understand what's going on with that individual car and then the cars in their proximity. In many ways, and it's a lot of information, in many ways, the infrastructure we were building in healthcare also needed to understand the map of all medical knowledge, what was going on with an individual and what was going on with that individual in their health system. And so it was actually quite fortuitous to be able to work cross-disciplinary. So whereas I came in with the background of clinical medicine, clinical trials, working a lot with regulators. So how do you actually get these products approved and into the hands of patients and clinicians? What was nice is I was able to work with really tremendous individuals with technical expertise. And that just has turned out to be one of the highlights of, I think, my journey thus far. So I was there. We were able to also, we ended up creating a company inside of Alphabet called Verily, where we were using a number of different analytic techniques, including AI. And what it reminded me of is much like when I talked about the landmarks in genomics, AI is not new. So AI has been around in many different shapes and forms. And in fact, this video that you can find called The Thinking Machine is from the 1960s. It's quite entertaining. It's probably worth taking a look. But you can see how a lot of the early technologies were there and how the hope was there. And there's a really nice article that I'm referring here talking about what's happening at Stanford with medicine. So if you want an overview. But there were a lot of landmarks. This is not new technology, but it also hit a similar exceptionalism. And again, I've seen this now in different waves. I think when you get to a certain stage in your career, you can start to see parallels to other types of technologies that have been rolled out. And I'm including here, this is an article from the 1980s talking about setbacks from artificial intelligence. And this was one of the AI winters that people refer to. And then again, we talked about genetic exceptionalism. There was a lot of talk about AI exceptionalism. And there was a call for a clear framework to evaluate these tools, to evaluate AI, to evaluate digital health. And what that harkened to me was going back to my experience with clinical trials. In the same way we wouldn't just give a medicine out to patients without testing it, we shouldn't be, depending on the risk profile, be using AI algorithms to triage patients unless we understand those quadrants I showed you, the safety and the efficacy. So again, there's some interesting observations. Nonetheless, the reason I'm so excited for the work that you're doing and the work that AIMI's doing and why I'm paying attention here is that there are a lot of advances. We now have distributed computing. So it's different than what I told you about even years ago, and we can talk more in detail. We talk about collaborative development models. So it's not each person unto their own. And the data sets are getting bigger. There's some debate, are the data sets big enough? But they certainly are getting bigger. And then on a clinical perspective, I think people are being more intentional. So when people are working with data, they're not just trying to fish and find a problem, but actually using the tools to address specific problems. There's trials and evidence generation. So you have people who are coming in and saying, how can we come up with the right framework to test these? And that's called implementation outcomes frameworks. So a lot of advances that are exciting. And what that led to, and I mean this in the most exciting way, this plateau of productivity. That means, in my mind, we've had some excitement, we had some disillusionment, but this is the moment. What you're working on and what we are working on and things that I'm seeing are actually helping people. And I'm going to go through a few examples and then we'll open it up for questions. So where I see value is in 4 different areas, and there are more, but I try to bin them into ways that we can conceptualize. One is using AI to scale healthcare. The second is to expand access, to help with communication, and to help with insights. And there are many examples that fall into these bins. I'm just going to give you one from each of them and some that are closest to my life so that it gives you some sense of where the field's going. Okay, so starting with scale. When I talk about scale, I talk about areas where we just don't have enough humans to actually take care of the work. And so one area is diabetic retinopathy. So people with diabetes, which is a certain condition where the body doesn't handle blood glucose appropriately, people can end up with changes in the back of their eye called retinopathy, and it can actually lead to blindness. Now, we know that patients with diabetes should be screened for this condition, but there are about 420 million people with diabetes worldwide, and we just don't have the capacity. So when I was part of Verily and along with our colleagues at Google, what we did is we started to train algorithms on diabetic retinopathy. And as it turns out, they became significantly better than human operators, and we were able to scale. Now, it's not that maybe the best operator could be doing this reading, but what we saw is that when we looked across human readers, they agreed with themselves only about 65% of the time and agreed with each other only 60%. Whereas the algorithms over time, because they were trained based on these human observations, but based on them in aggregate, they became much more powerful. And to date, you can see there's an Age of AI video that outlines this. Over 200,000 people have been screened and over 5,000 are getting screened weekly. So this is the idea of scaling, taking, again, humans need to come in, they need to help treat these patients, but it's a way of scaling a technology and helping people. The next example is access. So certainly in certain medical centers, people can get the ultrasound, and ultrasound is one way of looking at the heart. So it's another imaging modality. So we looked at a minute ago at retinopathy, so that's an image of the back of the eye. Here I'm showing you images of the heart, but it typically takes a pretty savvy ultrasonographer to get these images. And what researchers did is they took about 5 million different images of the probe, which is what you get the ultrasound images with, and matched them with the different images to try to align them and find exactly how to hold the probe to help a novice get the images. And as it turns out, it worked. And so now there are different areas scaling image acquisition. In the middle panel, you're seeing a group from the American Society of Echocardiography, so cardiologists being able to use point of care ultrasound matched with AI to come up with early diagnostics. And there's even now a vision paper out for the future of how to use these tools. So this is not this disillusionment. This is real care that's going on today that's powered by AI. And then as I round out these two other examples, one is in communication. So we spend a lot of time in medicine or just in the world explaining what's going on. And, in some ways it's a real luxury to be able to train. I talked about the training that it takes to go into these fields, but we have to be able to explain to our constituents, to the people we serve, what's going on. And sometimes we either don't have the time or we don't have the actual tools. And so just as an example, and this is being embedded in a number of hospital systems where emails are being at least initially drafted using AI, or this is an example that I used using ChatGPT. And I put a standard prompt that I might say to a patient, reminding a patient to remember to take their antiplatelet medications. I talked earlier about some of those that were important, and call the number if you have any questions. And then I asked, what data do you have to support this? So if I was talking to a cardiology consult and that came out quite quickly, then can you translate this into 20 different languages? As it turns out, many of us are practicing in counties where English is not the first language. And then finally, what's the rationale you might explain to a patient using different levels of health literacy? And this was all done in a matter of minutes. And so I think there's a real opportunity for communication. The other example for communication, and this one's a little controversial and probably one you've seen a lot of doctors point to this, but it looks at comparing physicians and artificial intelligence when answering patient questions. And the outcome was actually that the chatbot had potentially higher quality and higher empathy. Now, we have to realize that it also had infinite amount of compute and time, whereas we are time limited. But I think it suggests that there may be an intersection to use these tools and also help clinicians get through their day. And then the final one is around insights, biological insights. This was work that I was part of when we were doing this work at Verily. I talked about patients with diabetes and how when they have certain glucose levels, they can have problems with their eyes. Another issue with diabetes is understanding what your glucose patterns look like. And there's a tool called a continuous glucose monitor, and you see examples of those. And those map what your glucose looks like over time. But as you can imagine, you get a huge amount of data. So I'm giving you an example on the bottom. And if you stare, you can see there's probably an excursion on Friday where an individual person, maybe they go to their book club, or maybe they're going bowling, and maybe they're having more snacks then. But we were able to use analytics to extract that information and surface it to individuals so that they could either change some of their dietary patterns then or change their medicines. And again, these are insights that are much more personalized. We can't do these. We don't have the human capacity to do this. And then we ran a clinical trial. And what we showed is by using these insights, we could actually reduce someone's hemoglobin A1C. That's a metric of how high the glucose is in your blood over a period of time. We were able to significantly reduce this. So it goes back to the idea, it's great to have an insight, but unless you know that it improves someone's health, it's hard to get it institutionalized. So this was a nice combination of using new tools and technologies and also showing that it worked. And nowadays, they're insights more broadly. They're biological insights into drug discovery. We have AI-designed molecules that are entering clinical trials. You all know about AlphaFold predicting protein structures. We're now thinking about antibodies, and some of the work I'm doing with the companies that I'm involved with are really thinking about how do we take basic biological constructs but push them forward. So a lot of work being done, I think, on the insights phase, and it's a place where I'm particularly excited. So as we round out and we think about this journey, I wanted to make sure that we didn't end without talking about considerations. Many of you I know are working on intentional adoption. I'll call it 3 of these. Bias, so bias in terms of the model developments. I'll talk briefly about security and privacy. Cybersecurity is becoming a major topic of concern and interest. The important thing is just to pay attention to it and make sure we have a framework in place. We can talk more about that if that's of interest. And then the final one, all of these points are important, but I also wanted to just talk about the digital divide and this idea that we have to make sure that the tools that we put out there actually can lead to better health equity. And I'm helping mentor someone on a grant that's looking at just those considerations. But I like the fact that we're being deliberate, and I had the good fortune of being part of the Raise Health Symposium, which is responsible AI work that's being done at Stanford just to talk about these issues. But I think if we do this well, there's just a huge amount of opportunity. So thank you for sticking with me on this journey, really talking about technology and humanity through the lens of clinical trials, genomics, and data and AI. And I am open to questions, and I just know the future is bright with all of you doing this work. Over to you.
Hey, thank you so much. That was such an informative talk, and I thought it was really interesting how you talked about always thinking about the patient first. Those 4 values, of course, scale, access, communication, insight, and also how you talked about life is not always linear. It's always changing, and I think that's like something that applies to like everything. Like given technology and health, it's always changing. The field is always changing. So I thought that was really interesting. So I guess one question that I have is, considering there's a lot of high schoolers here, do you have any advice for what a high schooler can do to get started in this field, or how they can start working towards creating an impact in this place?
Yeah. So 2 things. One is high school is, I just think, such a formative time. So just paying attention to things that interest you, right? Because AI is going to be a tool that's going to accelerate the work you do. So you do want to understand the technologies deeply, but I believe just keeping an open mind in areas where you want to focus. So that's one thing. Then from a technical perspective, one thing that has really been democratized that's very different from when I went to school is the access to many classes, whether it's the programs through AIMI that you're doing, whether it's online webinars, whether it's actually deep technical classes that you have access to. Again, you almost have to, it's tough not being, I think sometimes people get overwhelmed and they want to be an expert. I mean, I know I do. You want to be an expert, but it's such a great time to just explore. So I think that combination of understanding the disciplines and areas where you want to have impact, and then just exploring, seeing what's out there, playing with the tools, getting your hands dirty, because in some ways there's nothing better than that. And the reason I share some of my experiences with genomics is it's an area where I can talk about how hard it was at first. It was really hard for us to handle the data. And at one point I thought, gosh, can I just publish a proof of concept, just that the data is organized? Like so much had gone into it. And then I realized actually probably not, but I could share my learnings. And I think you're going to find a similar thing. It's just, and the fields are changing really quickly. So in some ways, my final point was, I think you have a huge advantage because you're nimble and you're able to, there's the kind of the concept of being digitally native. And so I just wouldn't be intimidated. So understand the area, learn the technologies, and then do it with vigor. You're as close to being an expert as many people.
That's so cool. So we have a question from Nikith in the chat. Kind of similarly, like what path did you take with your education to gain the experiences that you did? You're a great medical doctor, but you also worked at Google. So how should a high school student maybe proceed with their education in to work in a field similar as you?
Yeah. So what I found, I always had kind of one person described it, and I guess this is more of a college thing, but you have a major and then you have a minor, right? So what's the piece where I feel like I've always had true expertise, and that is really clinical care and deep training in that. And even when I went over to Alphabet, I mean, that's what I came in really sharing those expertise But what I found personally really rewarding was looking at, so that was my major, but looking at my minor, or what was the interdisciplinary nature. And so in many cases, I had to go and chart a path that was not, it wasn't out there. So that was certainly true when I went to Alphabet at the time. I had to spend a lot of time understanding not only the work that was being done, but I really want to understand, what kind of training did people have? How did product managers work with program managers who worked with technical program managers who worked with our software engineers who did front end and back end? And it just, really getting a passion for understanding and becoming bilingual. And in fact, I became very close with our chief technical officer who has a background in computer science. And the more we spent time together, I think the better the work was. So to summarize, my sense, the reason I've been able to be part of different fields, I think honestly, it probably goes back to that early move to North Carolina, realizing that life isn't linear and that you can have one path, but you're going to have to sometimes just try a few new things to find that next journey. So that's my advice.
Yeah, that's some great advice. So I guess the next question we have is from Faye. Given the challenges associated with integrating genomic data with clinical and environmental data, what are some of the most promising approaches or technologies currently being developed to address these challenges and enhance the utility of genomic information in clinical decision making?
Yeah, great question. So there have been a lot of advances since the early days that I talked about. So one of the biggest advances is that we no longer are just limited to on-prem compute, right? So we can use the cloud, we can share, there are now platforms where we can share data with other researchers, we can upload data. One of the ones that we worked on at Verily was in combination with the Broad, and it was a platform where you can handle multidimensional data. And so there were actually channels optimized for genomics data, clinical data, single cell. And so there have been a lot of advances, usually on top of the cloud platforms that are out there to help us. So it's not to say that it's easy, but it's much easier than it was before. The other thing is now there's much better access control. So you can collaborate with other people, know who's using the data at what time. That was always an issue as well. So you can imagine me carrying around, I remember it's a maroon external hard drive. I mean, I would hand it off to my collaborator. He would take it home at night and then I would take it the next day. I mean, it just really painful. And we use this program called Plank, if anyone wants to look it up. And now again, we've made huge leaps in terms of being able to understand and handle the data. That's why I think there's a real opportunity now to be asking the questions. So there are a number of different really significant advances. So it's a good time. I'm not saying it's perfect, but it's a good time. The other thing I will say is sometimes it gets hard. The world is very specialized. You have people who get really deep in one data type. So I would encourage people to surround yourself with people who understand the different data types, because that's, I think, going to be important in the long run.
Wow, that's so cool. So speaking of kind of more making advances in kind of all these different technical fields, we have a question from Shrikari about how do you go about kind of transforming some of these advances into, say, a business or a company? What are some of the challenges that go along with that, and how do you address those?
Yeah. So one amazing piece about being in academia is you get to really question, you're always pushing the forefront, right? And you're always able to think about, new ideas and test them. What's nice about when things then get translated, where industry sometimes comes in, is how do you actually scale ideas? And there's certainly a lot of innovation that happens in industry as well. The things I've seen that are really important is, and we'll use an example. Let's say you have a algorithm that detects heart attacks. Well, it's an algorithm that uses multidimensional data to detect heart attacks. You might be able to study that and come up with an early prototype. But if you're then going to deploy it, let's say to patients, and it's going to be a type of device that gets medically cleared, you need to make sure that you're doing several things. One, and I'll be kind of technical for a minute, you need to make sure that there's a quality management system. So it's really important to understand the design controls, what inputs are going in, how is the information being handled, how are you handling certain risks along the way? So that's a quality management system. You need to work with regulators to say what endpoints are important. How many, does it have to be 100% accurate in terms of predicting heart attack, or can the sensitivities and specificities be in the 90s? These are the types of questions you talk about with regulators, and you look to see, there's a device that's similar, is there a predicate device, and you figure out your regulatory pathway. And then you need to figure out how it's going to get paid for. So you work with groups like CMS, you work with groups in the UK called NICE. There are a number of different areas, but you need to get reimbursed because that's how these products end up getting scaled. So it's important. The thing in industry, and the thing that's really exciting, is you have products that are deployed at scale, but you do have to think about all of those different pieces that get you to that endpoint. And I actually think some of the best work can come at the intersection of public and private partnerships. But that's just from an industry perspective, some of the key components and some of the key groups that you need in these businesses to make sure that you have impact.
Yeah, that's really cool. And I definitely think that it's really important to kind of understand those key components of creating an impact with your business. So the next question is from Ashank. He says that he's very interested in de novo drug design and protein structure prediction. And he asks, where do you see these fields going, and what gaps or shortcomings persist that we still need to circumvent?
So I'll start with the optimistic view, and then if I was a contrarian view. So the optimistic view is that it took many, many years traditionally to understand how, for example, different proteins interacted. And they're also the way different chemistries interacted. And so there have been real advances with understanding these structures, which even gives us sort of novel ideas. One set of research that's out there recently was looking at certain infectious conditions that we didn't have a treatment for. These were resistant to our current treatments. And there was modeling that was done and kind of came up with new structures for antibiotics that might be valuable. And they were things, certainly we could spend a lot of time, humans could spend a lot of time and try to do all this, but to see what worked and what didn't work, the algorithms were able to surface components that were then used by clinical chemists to say, okay, here are the ones we want to use. So the ability to, and this is where people talk a lot about hallucinations and AI and hallucinations. The great thing is that in science, it's wonderful. Let AI come up with all these different possible solutions. We can then parse through a few of them and pick what's most right to take into clinical care. So the positive side is we're looking into biology and we're seeing unknowns. And this is, to me, some of the most exciting work. I'll digress for 1 minute in pathology, looking at pathology, which is, when you take tissue and you look at it under a microscope, there's a lot of interesting observations there that we just can't see with our human eye. So I would say the ability to see new patterns is very interesting. And there are now several drugs that are in clinical trials right now. The contrarian view will say, we still need to test these medicines in humans, which is very true. But unfortunately, in some cases, it's really only 1 out of 10 drugs that are being studied actually make it to clinical development. So if we can increase the odds a little bit, then that's good. But again, the more sober view is we still have to do clinical testing in humans. And the other thing is people talk about the dynamism of proteins. So you may study them in silico, but actually in the human body, because the human body is so dynamic, proteins can change. So I want to give you the full view, and it's early days, but I think certainly as a tool to help with drug development, we're seeing a lot of very real and tangible examples.
Wow, that's cool. In kind of that area of how do we really test these algorithms and make sure that they're working and doing what we want them to? We have a question from Noreen. So given the rapid pace that kind of these technologies are evolving, how do you think we really kind of balance between scaling quickly and kind of having more of these technologies, but also ensuring that it remains ethical?
Yeah. So I always step back and say it depends on the implication and the use. So, we're using algorithms all the time to help us navigate the world, right? So everyone's using maps. We've seen that there's a real benefit. Occasionally, you probably read about examples where people drove off the road, or so there are cases where you could say, is there a concern there? But in general, we use algorithms in that case because the benefit is there. When it comes to healthcare, they're different tiers. So some of the tiers are what we call helping with. I'll give you an example. So when we see someone, we then do medical billing, and there's a coding attached to that. And periodically, so I manually code for my visit, and then periodically I'll get outreach from the coding office that says, hey, you didn't code this, can you go back? These are different things where it's pretty low-hanging fruit to look for anomalies, looking either at our notes and looking at what we coded, where in general, the risk is lower, and that we're not immediately giving someone one medicine or another. We're thinking about how to code it. It certainly matters tremendously in the enterprise, but there are ways where we can test whether it's generating the right codes or not. So I think you're seeing a lot of early use cases, and people sometimes call it just kind of the nuts and bolts of medicine. Places where if you're getting closer to these higher risk devices and higher risk medicines, what's nice in medicines, we actually have a framework. We work with the FDA. In Europe, we work with the EMEA, and internationally, we work with groups. And so if, for example, you were coming up with an algorithm that was supporting whether someone gets a defibrillation, so they have a funny heart rhythm, we're worried that it's something called ventricular fibrillation, and you have a discharge and you're trying to have a more savvy set of discharges, well, that's a medical device that already has its framework. So a lot of it is really based on the risk framework. I believe that we're going to continue to try to move as quickly as possible. I know people a lot of times turn to regulators and say that's really the issue. I've seen actually regulators try to partner. So I think there's just going to be a balance of risk curve. So to summarize, some places are going to move super quickly, and then if it's a more kind of risky device, we're going to be following our pathways that we've had for years. But again, the nice thing, unlike other fields, we actually have pathways. So in social media, it's unclear what the risk curves are. There aren't the same pathways that we have in medicine and healthcare.
Yeah, definitely. So our next question is from Clara. She said, I love the portion of the presentation about genomic data, and I'm curious about further applications of AI in such field. How can AI be applied to pre-existing genome engineering technologies such as CRISPR, PCR, etc., to collect and analyze genomic data?
Yeah, there's a great paper that just came out, and it essentially took all of the genome-wide association studies that are out there, and then started to, again, beyond what we could do with the human eye, start to look for the patterns. And there's a concept called Mendelian randomization, where you look at people across a population and you look to see, do they have certain variants, and then what are their downstream outcomes? And one example where insights from genetics led to a medication is through a gene called PCSK9. So PCSK9 is involved in the cholesterol pathway. Cholesterol is involved with heart disease. And so looking at that particular gene, we were able to create medicines that are PCSK9 inhibitors. Now, that was just one example. Now people are using much more complicated and interesting computational techniques to look for broader applications. And so again, there was an example that there might be other low-hanging fruit in terms of targets that we can find from the genome. So that's an area, certainly if you're interested in it, I would follow up with it. I really do think there's going to be hidden information even in data we've already collected. So that I think is one observation. And then in terms of CRISPR and some of what we call genomic medicine. So there's just for people who don't spend as much time in this, there's looking at genes and trying to predict, do certain genes cause outcomes? And then there's actually going in and modifying the genome. So that's where concepts like CRISPR come in. And certainly people are looking at new, are there new and different ways, not only of the CRISPR technology, but also of the delivery. Many of these CRISPR compounds are delivered with different nanoparticles. So it's both in the observation studies and in the design of the therapeutics that you're seeing AI being used.
Oh, neat. So yeah, you're super interested in genomics. We have a question from Dicha, about like what other projects have you been really proud of or really enjoyed working on and why? Could be in
Yeah.
genomics or outside.
So I'll bring up two. One is I showed you, and this will have both a scientific and a collaborative science angle to it, which is why I like it. So the work I showed you looking at genetic variants in the cytochrome P450 system, and particularly CYP2C19. This was work that we were doing, and a lot of times you do work in isolation. I mean, isolation meaning I was working with a team of investigators, but we were working together over here. And we came up with the observation around these particular variants. That it was interesting to me because it was a medicine that was used frequently. We then ended up working with the FDA. They actually changed the label. So there's a thing called a package insert. So any medicine has a label, but it ended up informing the label. And then there were studies to go on to design new ways of thinking about using the medicine. So it was impactful in that way. The thing that was interesting from a social perspective is there was another group working on a similar study. We just didn't know it, and we found out only when our papers were published at the same time in the New England Journal of Medicine. And they were slightly different. There was just a little bit of, and at first they tried to pit the two of us against each other, like who's right and who's wrong. But we realized by actually combining our data sets and then expanding to 7 other collaborators internationally, we really came out with ground truth. And so this person to this day is still one of my closest friends and collaborators. And I think it helped science. So to me, that's both a scientific and a personal achievement. In terms of more recently, some of the work we did at Verily that I'm particularly proud of is really thinking about multidimensional data. And we worked with Duke and Stanford on a study called the Project Baseline Health Study, which now is just starting to really be analyzed. It took us a period of time to get the data, but this is the deepest dive into human health. And so understanding everything from how people use devices to molecular signals, to sleep and environmental impacts, it forced us at Verily to create a lot of new technologies to handle multidimensional data, including creating a study watch. And then now the outputs are coming out. So yeah, so just different phases of life with different things that are that took a lot of people to work on. I guess maybe a theme is I'm proud of the work, and I'm particularly proud of the people I got to work with on it.
Yeah, that was really cool. It's especially how you published a paper at the same time as the other people, and it was really cool how you guys could work together like that and kind of create some ground truth there. So we are heading to the end, so I think this would probably be the last question. So I see a question from Abigail. She says that in the AIMI bootcamp, they were looking at whether or not continuous machine learning models should be considered for clinical practice or considered as research. And what is your opinion on this, and what could this imply for future patient-doctor relationships?
Yeah, so several things. I'll give kind of a real example where there are, it's very true. A lot of times when you look at approvals, typically you lock an algorithm or you lock a device of, when something gets approved, or maybe the most basic is looking at a medicine, right? The formulation is set. The beauty of a lot of these AI guided pathways is that they continue to improve. And there's now a way I think that this can be done responsibly. So certainly what we've done in the past, and I've done with several products, is really looking at how the data is used and what are the guardrails as you it's essentially looking at confidence intervals, like how much are you changing? And if it's and you want, it's really the concept continuing to monitor what those outputs are. So I think it's unrealistic, and we truncate the beauty of this work if it's static. But then what that means is you can't launch something and then just turn away and it sort of self-regulates. We've seen problems with that. We've seen algorithms being used to detect things like sepsis that then people didn't tend to, and then they drifted. So the short answer is there's a way to do it, and there's a way to do it responsibly, but it is going to take this more continuous evaluation framework. So yeah, so the it's a great question. And I think one where the landscape continues to evolve.
Yeah, thank you so much. I think so. We're going to start off with I think we've ran out of time for more questions. So, I just wanted to thank everyone. This was such an informative webinar. I'm sure everyone learned a lot about your career and also your use of tech in healthcare. It was so inspiring to see how you done so much research and worked so much in the intersection between tech and healthcare, and all of your small little stories in your journey was super cool to listen to. And on that note, we wanted to give you a huge thank you for all of your invaluable insights and guidance. I'm confident that what everyone here learned today is going to significantly benefit our future's careers and provide us with a unique perspective on AI in healthcare.
Yeah, we
Well,
also want to
thank-
thank all of the participants for their time, asking such thoughtful questions, which really helped keep this webinar educational for everyone. And of course, thank you to Amy for planning this wonderful event and making this all possible. As a heads up, the next AIMI NextGen TED Talk will be on Monday, August 26th at 5 p.m. PT. There's going to be a registration in the Zoom chat, and that'll also be emailed to you. And the recording for the session should also be available on YouTube in the next few days. So thank you all again.